morning, and today I'd like to read to you another pamphlet I wrote against the privatisation of the NHS. This is Don't Let Cameron Privatise the NHS. As you can see, it was written several years ago when David Cameron was then Prime Minister. Before he bailed out after the debacle of the Brexit vote, which he called thinking the anti-Brexit forces, the Remainers, would win, and then got a terrible shock when he lost. But instead of staying to deal with this problem, he immediately bailed out and left it to others. Well, so much for Dodgy Dave and the way he runs this country. Now, the Tories have been very, very keen on increasing private involvement in our National Health Service for decades, ever since Margaret Thatcher really wanted to sell it off but couldn't because of a cabinet revolt, and then denied that she did. Now, as this shows, the cover meme shows there were any number of Conservative MPs with deep interests in the private health industry, including, of course, Ian Duncan Smith. Now, some of the faces have changed, the determination to privatise the NHS hasn't, and the Blairites in the Labour Party share it. So perhaps I should really say, don't let Keir Starmer and the Tories privatise the NHS. It's only got 10 pages, and it shows you how privatisation undermines, even piecemeal, undermines the NHS, leads to worse healthcare for people, and is generally incompatible with the principles under which the NHS was set up. I'll begin. Visiting our local health centre the other day, and my parents, along with the other local people enrolled there, were handed a letter explaining that due to funding cuts, the health centre was having to cut back on services. It also advises patients that if they wanted to raise their concerns about the restriction in this service, they could contact 1 NHS England at FAO Linda Prosser, Director of Assurance and Delivery, NHS England South West, BNSSG, 4th Floor Plaza, Marlborough Street, Bristol, BS1 3NX. Or my local MP at the House of Commons, Westminster, London, SW1A 0AA. Unfortunately, this is happening to the NHS and GP services all over the country. It is no accident, and it is certainly not the fault of the many dedicated doctors, nurses, and other health professionals working in the NHS. It is the result of over 30 years of privatisation begun with Margaret Thatcher. Thatcher and her former Chancellor, Nigel Lawson, denied that they wanted to privatise the NHS. They merely stated that they wanted to include more private provision in the NHS. This is a lie. Released cabinet minutes showed that Thatcher and Geoffrey Howe wanted to privatise the NHS along with abolishing the rest of the welfare state. They were only prevented from doing so because the rest of the cabinet realised that this would be the death knell for the Tory party. And a fact-finding mission to the US to see how their private healthcare system worked by Patrick Jenkins showed that it was massively inefficient. Nevertheless, the amount of private healthcare in the NHS was expanded, and state provision duly cut by successive governments. It was Maggie's government in 1989 that ended the state support for care for the elderly in nursing homes. As a result, the families of those who need this kind of care are forced to fund it themselves, either through selling or remortgaging the homes. Often through selling or remortgaging the homes because of the immense expense. It was also Maggie's government that ended free eye tests and picked a feud with the doctors that saw the majority of them leave the NHS. This privatisation has continued under Tony Blair, Gordon Brown, and now David Cameron and Jeremy Hunt. Blair and Brown were deeply impressed with American private healthcare firms such as Kaiser Permanente and wished to reform the NHS on their model. The ultimate intention was to replace the publicly owned and operated NHS with private healthcare funded by the state but administered by private health insurance companies. As a result, NHS work has been given to private hospitals and clinics, and private healthcare companies have been given NHS hospitals to manage. Alan Milburn, Blair's health secretary, wanted the NHS to become merely a kite mark, an advertising logo on a system of private healthcare companies funded by the government. This has been carried on by the current Conservative government, and they have used the same tactics Margaret Thatcher did to force private healthcare on this nation. The dispute with the doctors over contracts a few years ago was part of this. It has left the majority of NHS GPs wishing to leave, yet elements within the Conservative networks responsible for foisting these demands have seen this as an opportunity for forcing through further privatisation. Penny Dash, of the National Leadership Network, one of those responsible for the NHS privatisation, has looked forward to the remaining GPs forming private healthcare companies. Furthermore, a report on the care commission groups now in charge of arranging healthcare in the NHS by one of the private healthcare companies also suggested that they could form private healthcare companies and float shares on the stock market. Further privatisation has come with Andrew Langley's Health and Social Care Bill of 2012. This exempts the State and the Secretary of State for Health from their statutory duty as the ultimate leaders of the NHS to provide state health care. It is carefully worded to disguise its true meaning, but that is what has been intended by the bill. Dr. David Owen, one of the founders of the SDP, now part of the Lib Dems, has tabled amendments trying to reverse this despicable bill. He and many others have also written books on the privatisation of the NHS. One of the best of these is NHS SOS by Jackie Davis and Raymond Tallis, published by One World. This process cannot be allowed to continue, and I strongly urge everyone to resist the creeping privatisation of the NHS, Britain's greatest public institution. In the last government, there were 92 Conservative and Lib Dem ministers who advocated the privatisation of the health service and who stood personally to gain from it. They included Ian Duncan Smith, the Minister for Culling the Poor, the Sick and the Old. Andrew Lansley, the Health Minister, openly stated he is in favour of privatising it. So has Nigel Farage and the Unterkipper Gruppenführer Paul Nuttall. This was the UKIP as then. Farage in particular follows the Tory policy going all the way back to Thatcher of promising to defend it or secretly plotting how to sell it off. Thatcher's review into the NHS and its funding in the 1980s so alarmed Labour's Robin Cook that he wrote a Fabian pamphlet, Life Begins at 40, in defence of the NHS, attacking possible proposals to privatise the health service. Well done, Robin. Previous reviews have given the NHS a clean bill of health. The extremely high quality of the NHS and its doctors was recognised by the heads of American healthcare firms. Dr. Marvin Goldberg, Chief Executive of the AMI Health Group, told a Parliamentary Select Committee that the health service provides outstanding health care and the British NHS hospitals are at least as good as those in America, while British doctors are better. Possibly no longer, due to the Tories. The then Conservative MP for Newbury, Michael McNair Wilson, also testified to the effectiveness of the NHS. He had suffered kidney failure. He had private health insurance, but it did not cover operations such as the one he needed because of the expense. This is the problem with private health insurance. He said, I have cost the NHS tens of thousands of pounds. Much more than I could have afforded privately. Had my treatment depended on my ability to pay, I would not be alive today. This is the real situation in America. Pre-NHS Britain, some areas completely without hospitals. Cook's pamphlet also graphically described the patchwork state of healthcare in Britain before the NHS. In London, where there were plenty of paying customers, there could be hospitals in neighbouring streets. Out in the poorer British provinces, there were hardly any, and many operations were carried out not by surgeons but by GPs. He cites Julian Tudor Hart's book, A New Kind of Doctor, to show how bad this could be. Hart described how he joined one of those practices in Kettering. The patient was left under an anaesthetic as the London specialist operating on him was called away to continue a stomach operation on a London patient, which the operating GP had been unable to complete. Cook was deeply concerned that the Tories review would not be at all interested in improving quality, only in opening up the NHS to the market and privatisation. He was very prescient. Cook on private health insurance. One of the issues he tackled in the pamphlet was the possibility of the introduction of private health insurance. This covers 2 pages and a column and a bit in the original pamphlet. This is what he wrote, though the emphasis and paragraph titles are mine. The mechanism proposed to square the incompatibility of healthcare with the market is insurance. All market approaches to the NHS submitted to review stress the case for much wider private insurance and almost as frequently propose subsidies to boost it. Insurance-based systems encourage expensive treatment. The first thing to be said is that private insurance does not offer to healthcare the alleged benefit of the discipline of the marketplace. Robin continues. At the point when the individual requires treatment, he or she has already paid the premiums and has no incentive not to consume as expensive a treatment as can be reconciled with the policy. The position of the doctor is even more prejudiced in that he or she has every incentive to obtain as much as possible from the insurance company by recommending the most expensive treatment. Both patient and the doctor are in a conspiracy to make the consultation as costly as possible, which is a perverse outcome for a proposal frequently floated by those who claim to be concerned about cost control. Insurance-based systems encourage unnecessary surgery. The compulsion in an insurance-based system to maximize the rate of return is the simple explanation why intervention surgery is so much more often recommended in the United States. For example, the incidence of a hysterectomy there is 4 times the British rate. This is unlikely to reflect higher morbidity rates, but much more likely to reflect the greater willingness of doctors on a piecework basis to recommend it, despite the operative risks, and in the case of this particular operation, the documented psychological trauma. I can guarantee that an expansion of private insurance will certainly meet the objective in increasing expenditure on healthcare, but it is not equally clear that the money will be spent effectively. Insurance-based systems require expensive bureaucracy to check costs. One direct diversion of resources imposed by any insurance-based scheme is the necessity for accountants and clerks and lawyers to assess costs and process claims. The NHS is routinely accused of excessive bureaucracy, frequently, I regret to say, by the very people who work within it and are in a position to know it is not true. Expenditure in the NHS is lower as a proportion of budget than the health system of any other nation, lower as a proportion of turnover than the private health sector within Britain, and come to that, lower than the management costs of just about any other major enterprise inside or outside the public sector. I am not myself sure that this is a feature of which we should be proud. On the contrary, it is evidence of a persistent undermanaging of the NHS, which is largely responsible for its failure to exploit new developments in communication, cost control and personnel relations. Nevertheless, there is no more pointless expansion of administrative costs than the dead weight of those required to police and process an insurance-based system. These costs will be considerable. They are, thanks to privatisation, the administrative costs in the health service is now heading up towards American levels, which are now 40%. 40% of personal bankruptcies in the US are attributable to debts for medical care. Part of this additional cost burden is incurred in the task of hunting down bad debts, which does not contribute in any way to the provision of healthcare. 40% of personal bankruptcies in the US are attributable to debts for medical care, a salutary reminder of the limitations set to insurance cover. These limitations have 3 dimensions. Insurance cover excludes chronic and long-term sick and the elderly. First, insurance cover generally excludes those conditions which are chronic and therefore expensive, or complicated and therefore expensive. Standard exclusions of British insurance policies are arthritis, renal dialysis, Multiple sclerosis or muscular dystrophy. Most people do not require substantial medical care until after retirement. Most insurance cover excludes the very conditions for which they are then most likely to require treatment. Short of retirement, the most expensive health care required by the majority of the population is maternity care, which is also excluded by the majority of insurance policies. Private healthcare limits the amount of care due to costs, not need. Secondly, insurance cover is generally restricted by upper limits, which are arbitrary in every sense other than financial. I recently met a psychiatric consultant to a private clinic who was prepared to discuss candidly the ethical dilemmas of treating patients whose financial cover is fixed at 5 weeks of residential care, but whose response to treatment may indicate that a longer period of hospitalisation is desirable. Private healthcare geared to selling healthy, not sick. Thirdly, insurance cover is further limited by exclusion of those most likely to claim on it. I am often struck at the sheer healthiness of the patients who illustrate the promotional literature of BUPA and PPP, who appear in such pink of good cheer and fitness that it is difficult to figure out why they are in a hospital bed. These models are though in a sense most suitable for the purpose, as the objective of the insurance companies is to attract the healthy. They therefore claim the right to screen for the unhealthy and to reject them from cover. This discriminatory approach was defended earlier this month by the managing director of WPA, Britain's third biggest health insurer, on the principal grounds that it meant essentially healthy people are not penalised by unhealthy people. This statement has the advantage of originality in that it perceives healthy people as the vulnerable group and proposes a market remedy that protects them from the inconvenient costs of the unhealthy. Given this limited character of health insurance in Britain, the private sector is patently not in a position to substitute for the NHS, and to be fair, most directors of BUPA or PPP will be horrified at the notion of accepting the comprehensive, open-ended liabilities of the NHS. It is therefore perplexing that so much effort in and around the review appears to be addressed to the issue of how the private sector may be expanded rather than how the public sector may be improved. Two major devices are being canvassed to boost private cover: tax relief on private cover or opt-out from public cover, or for all I know, both of them together. Both would be a major mistake. Tax relief on private healthcare. Tax relief is open to the obvious objection that it targets help most on those who need it least, the healthy who are most likely to be accepted for private cover, and the wealthy whose higher tax rates make relief most vulnerable. These are curious priorities for additional health expenditure. Tax relief does not create higher spending on healthcare. Moreover, even in its own terms of stimulating higher spending on health, tax relief is likely to prove an ineffective mechanism. If, for example, the average premium is £200 per annum, the cost of tax relief for 6 million insured persons will be 300 million. The numbers under insurance need to increase by a third before the increased spending on premiums matches the cost of the subsidy and provides any net increase in health spending. Up to that point, it will always produce a larger rise in health spending to increase the budget of the NHS by a sum equivalent to the cost of tax relief. It is apparently being mooted that these objections could be circumvented by limiting the tax relief to the elderly. At this point, the proposal moves from the perverse to the eccentric. This restriction targets help for private insurance on the very group for whom private cover is most inappropriate, as their most likely health needs are the ones most likely to be excluded from cover. Only a moment's reflection is required on the multiple ways in which we need to expand our health provision for the elderly to expose the hopeless irrelevance of tax relief as the solution for them. Opt-out penalises those who remain in the system. Opt-out is even more objectionable. The basic problem with opt-out is that it requires the payment towards the NHS of every individual to be expressed in a manner that gives him or her something to opt out from. The principal attraction to Lee and Britain of this proposal for an NHS contribution appeared to be precisely that it paved the way for opting out. A new deal for healthcare. Conservative Political Centre, 1980. It's always a new deal. even under Blair or New Deal. Nor is this inconvenience confined to the need for a whole new element in the tax system. If 1 in 10 of the population chose to opt out, it would be remaining 9 out of 10 who would have to prove that they were not opted out when they went along to seek treatment. With the new contributions comes a requirement to maintain a record of payment of them, and presumably a mechanism for credits to those not in work but who do not wish to be counted as having opted out of the NHS. Private healthcare undermines the NHS as a universal system. The most fundamental objection both these proposals is they explicitly threaten the NHS as a universal health service catering for everyone. Moreover, they threaten its universality in the worst possible way, by encouraging those with higher incomes and lower health needs to get out, leaving behind the less efficient and the less fit. In this respect, such an approach to the NHS would be at peace with the government's strategy of erosion towards the rest of the social services, housing, pensions, and now education, where the government has encouraged those who could afford it to opt out of public provision, leaving behind the poor who could be expected to put up with the poor service. How true. This is the reality of the private healthcare system. These are my comments now. Which Cameron, Clegg, Farage and the rest of the right wish to introduce. It is expensive, bureaucratic, does not stimulate further spending, and excludes those with the most acute and expensive medical needs, especially the elderly. And the Tories and their counterparts in UKIP and the Lib Dems know it. Why else would the Tories spend their time trying to deny what they're doing? Why does Farage appear to be advocating retaining the NHS when arguing for an insurance-based system like America? It's because they know private medicine does not provide the solutions they claim. It is only the source of further enrichment to them and their corporate donors. And since Cook wrote that pamphlet, more than 20% of all Americans can no longer afford their health care. It's why the firms are trying to get their feet under the table over here. Don't let them. Ed Miliband and now Jeremy Corbyn have promised to reverse the privatisation of the NHS. Please support them. Jeremy Corbyn has since come and gone due to libelous accusations of anti-Semitism, and instead we have Keir Starmer, who is now advocating more private involvement in the NHS to clear the backlog, or the waiting list backlog, which is what the Tories have also been advocating. It's a cover for further privatisation. Just get them out. Thank you for listening.